and welcome to the Weightcare podcast. I am your host, Sharon Polsky, and these are conversations on a new era of weight management and GLP-1 weight loss medications. And today I have a great show for you. I know I say that every time, but I really do have a great show for you. We will be talking to or having a conversation with Dr. Meagan Moore, who's an OBGYN with a specialty in hormones. And we are going to be talking about women's health and GLP-1 semaglutide and tirzepatide. And this is super exciting because so many of my weight loss clients had unwanted weight gain from things like insulin resistant PCOS. And they were overweight from the time that they were 12 years old. And then they found out in their 40s and their 50s that they had insulin resistant PCOS and probably had it from a very young age. And had they had access to this kind of information or these kind of medications, they would not have been forced to struggle with weight gain for the majority of their lives. And so I think that these conversations are really important. We need to normalize conversations around PCOS and menopause. And I went into menopause about a year ago. I gained about 8 pounds in 3 weeks. I already ate really, really healthy. I exercised for 45 minutes, 6 days a week. I also had an active job and had this weight gain that came out of nowhere. And I remember when my mom went through menopause, everybody just said to her, "Oh, well, you're lucky you only gained 15 pounds. I mean, other women gain much more," or, "Oh yeah, that's normal. Just get used to it." Or, "You should be happy gaining, 15 pounds. It could be worse." And nobody ever pushed back on that narrative. And now I find that women going through menopause, including myself, pushed back on that narrative. So when I gained that weight and I knew I couldn't adjust my diet and I knew I couldn't adjust my exercise to accommodate it, I asked the question, why do I need to suffer with this weight gain? Why can't I change it? And that's when my hormone doctor came to me and told me about GLP-1s. And I started using tirzepatide. And Dr. Meagan Moore happened to be my OBGYN. And I said to her the same thing. And she said, absolutely, they are safe. I've said this since the beginning of this whole GLP-1 thing. This is the biggest game changer I've seen in my lifetime working with weight loss clients. Personally, taking Mounjaro or tirzepatide was a game changer for me personally. It was the first time in my life I was never hungry. I was that type of person. I would eat a meal and be thinking about what I was going to eat in 3 hours. And I got brought into it because of menopause. But there were so many other benefits to me personally. So I want to have this conversation with Dr. Meagan Moore and talk about women's health and our GLP-1 weight loss medications. So I am so excited to welcome Dr. Meagan Moore to the show for conversations about women's health and GLP-1s. Welcome, Dr. Moore.
Great. Thanks for having me.
So happy to have you. So tell us just a little bit about your practice and what you do and how you've started integrating GLP-1s.
Sure. I'm an OBGYN in Orange County, and I have a pretty diverse practice. I do obstetrics still, but primarily GYN has become a biggest part of my practice, and specifically treatment involving hormones. I would say if I see 25 patients for hormones a day, 15 are talking to me about menopausal weight gain. So that was just GLP-1s became a really easy transition into my practice. I also see a lot of patients with PCOS. I've been treating PCOS for a long time, but it's very, very popular right now. I think, because the GLP-1s, but it's also really popular on social media. There's a lot of people that think they have PCOS that don't have it. And there's a lot of people that have it and they had no idea that they were struggling with that condition and, fighting a pretty difficult battle. So GLP-1s have become a big part of my practice for those patients as well.
Yeah. So let's talk about PCOS for a second, because I know I've had some patients that have struggled with weight gain from a very young age, like 13
Right.
years old, and had this undiagnosed PCOS that finally their doctors found when they turned 35 or
Right.
in their 30s. Why was there this big delay from diagnosing PCOS many years ago to being able to diagnose it now?
To be honest, if I'm going to be really honest, we're not really trained all that much in a lot of these conditions in our training, right? So you get trained and you're in there for 4 years and you're trying to learn how to do surgery and you're learning how to deliver babies. And hormone and endocrinology is a very small part of your training. So I think once you get out into the community, it takes a while to figure out what's going on with a lot of these patients. PCOS presents between 20 and 30 years of age. That's the reality of it. And if you are not kind of versed in treating that, or you haven't seen a lot of those patients, what inevitably ends up happening is people tell these girls, because they usually come in complaining of weight gain. Of course, they are very often having hirsutism, so hair on their face or areas they don't want it. But they are getting sent home and told to, improve their diet and exercise, which of course is important, but they are really so frustrated. It really affects their mental health. Depression's part of PCOS. And so, as you can imagine, a lot of these girls have seen multiple doctors before they get to that diagnosis. So, 10 to 15% of the population, they now say, has PCOS. And I think that's a fair estimate. So I think it doesn't get diagnosed, one, because people aren't looking for that. Two, maybe just not as much experience. And three, a lot of people think that PCOS has to follow these very strict criteria, right? So they think that patients need to have, irregular menses. They need to have ovaries that show it. They need to have hair on their face, and they need to have acne, and they need to be overweight. Well, not everyone is going to fit in that box. There's 4 very different types of PCOS. So it is not uncommon for me to have a patient that has elevated androgens and totally normal periods and a normal ultrasound. I may still think that patient has PCOS. And
then you'll treat it as if it was PCOS, correct?
I will treat it. And if they respond, one, it's therapeutic and diagnostic. So sometimes you're treating a patient that you're not 100% sure, does this patient have PCOS, but you feel like they fit the criteria and we're comfortable with the management and we know the meds that we're using are safe. I feel very comfortable using metformin, and I feel very comfortable using GLP-1s. I just had a patient today that, she's on metformin for PCOS. It has done great things for her, but it has done nothing for her weight. So even though she's doing better, she's like, my periods are regular. I'm not having acne issues, but what's going on? I'm still overweight. I said, I really think we have to consider converting you to a GLP-1. And there's roadblocks with GLP-1s, as you know, and it's mainly insurance companies getting it covered for patients. So,
and why doesn't the exercise, the calories in and the calories out, really work for those PCOS clients? Why do we need alternatives?
Right. So, it's if everything's working and you don't have this metabolic syndrome, which is what it is, decreasing calories and exercise, your body's going to do the right things with that, with the fuel that you're giving it. The problem with PCOS is they are having excessive release of these hormones from their brain. So they are very insulin resistant. So when those patients eat healthy, we can turn that healthy food into fuel. Their body can't take that food and make it fuel, so it stores it as fat. So it's a really simple concept, to be honest, what's happening to them. It makes so much physiologic sense. And it's just, it's exciting now to have a better understanding of what's happening to all these women. It's similar to what happens to women in menopause. Not exactly. There's a lot of differences, but there's a lot of crossover between PCOS and menopause for sure.
So is that why the calories in and the calories out stops working for women once they hit menopause?
Well, menopause has a lot of different factors. So insulin resistance is part of it, but the problem is the hormonal imbalance, the hypoestrogen, the hypoprogesterone can affect how we burn energy. It causes us to be insulin resistant. It causes us, when we do exercise, which we normally, we'll see a result, you're not going to have the same results because of the effects that estrogen has on gluconeogenesis, the effect it has on our cortisol levels. So as we get to menopause, we get insulin resistance, we get elevated cortisol, we have more glucagon in our body. So it's all these things that happen. And a lot of it's not, menopause is, the phenomenon of not having functional ovaries, but it's also the age you're at when that happens. So when I rarely do a hysterectomy or take ovaries out on a 30-year-old, I don't see that amount of weight gain that I see in my traditional perimenopausal patient that's in their late 40s or 50s. So everyone always says, well, you're older and that's just what happened. There's some truth to that, but it also has to do, with, it's not just hormonally mediated, that there's both of those things that play a role.
Yeah, it's hormone and age and where
And
you are.
age, not one or the other. It's both of those things together.
And then GLP-1s have just kind of been a new tool in the tool, but they're not that new. I mean, they were around many, many years ago, but they're more readily available now. But they've just become this great new tool for a lot of doctors, but they're not the only tool. But why are they such an effective tool for you to use?
I think because they have so many different they work in so many different ways. So it's not that they're just decreasing, gastric emptying, and they affect insulin resistance. They affect gastric emptying. There's a lot of different mechanisms that they work for. They are easy, even though it's an injection, it doesn't take a lot of, one shot a week. Patients can do that. And patients are different. Some people have these amazing results to them, right? You've seen them, I've seen them. And those patients probably had they were programmed to have a response to that. But there are some patients that you get them on pretty high doses and then they're not having that result. And those patients are just so typically insulin resistant, or they're just not having the response you want. So I tell people, I'd say 95% of my patients get a result, but there are 5% of people where GLP-1s does not get them over the finish line. And it's discouraging because there's not a whole lot of other options for the weight side of it in that population. Because again, exercise and diet, those are important, but it is unfair to send them out the door and tell them that's going to do the job for them. Because most of these people have tried that.
Well, they've all tried that. I mean, I've been a weight loss coach for 20 years, and we didn't have this tool in the toolbox until recently because it became mainstream. And it was such a lifesaver for my clients because my clients have been telling their doctors for years, I do exercise, I don't eat a lot. And the doctor basically looks at them and tells them they're a liar. Well, then you're just not putting in enough effort. You're not limiting your calories enough. And they go back and it's like victim blaming, right? They keep blaming the patient. And then we finally put them on a GLP-1. And you're totally right. The majority of my clients, 95%, amazing results. And that 5%, I mean, even on high dose, we're not even pushing that needle. And it is discouraging.
Yeah, I try to, for sure, in my practice, do the lowest dose possible. I'm definitely a believer in the steady. I know there's we get greedy. I've had patients that lose 10 pounds in a month and let's go up on my dose. And I say, no, 10 pounds is a lot of weight. So you have to be committed that this is not going to be a 2-month fix, because that weight is, I think you're going to have a big rebound on those patients.
Yeah, you are.
So if you want to have less side effects and you want to be able to cross over to microdosing, it's going to be hard to get you from 2 milligrams back down to what we're telling people to do from microdosing. So, and it's also going to be so much, more cost effective in the long run if you can lose it that way, and we can keep you on those small, whether weekly doses or every other week or every third week dosing, which I'm doing with a lot of my patients right now.
And all the clinical research was based on a year of usage. It wasn't based on only 3 months of usage. So we saw this great, especially with tirzepatide, we saw this great weight loss over a 1-year period. And I know that all the doctors I work with and all the coaches I work with, we keep talking about this. This is not a quick fix. And if you're looking for a quick fix, it's going to cost you a lot more money in the long run.
Oh yeah, because if you're going to gain it back on, you're going to have to restart over. So, I kind of have, there's the regimen that the companies tell you, right? They follow. I don't always follow that. So if I have someone on a low dose and they lost 3 pounds, the thing is, it's expensive, right? So the patient's like, oh my gosh, but in the long run, if we can get this to, reset those receptors, and you can get on such a low dose to maintain, because I do tell people that you may be on this for a long time. It may be like a thyroid medication. We don't have that long-term data yet to know. But I don't tell people you're going to be on this for 3 months and get off of it. I think that's unfair. And I think that they're going to rebound and it's going to be wasted money anyways. And it's just not money, it's their health. Right. And so we're seeing all these long-term benefits now, right? Dementia, heart disease. You're going to start seeing that because we know sugar in your blood is bad. So to me, this very quickly made sense. I was like, how could this be bad for you? And so it's been exciting to have all the data coming in to support us.
Yeah. And the other thing that I saw with a lot of my clients, and this is slightly off subject, but it's really not, a lot of my clients had a lot of inflammation, joint inflammation when they went into menopause. And then we put them on a GLP-1 and just that joint pain, back pain, inflammation went away. It was so mind-blowing because some of them are your patients that we share that I coach. And it was the first time that these women didn't experience hip pain when they slept at night, or back pain.
Or they slept at night.
They're not having my next point.
Right.
They finally got some sleep because of their GLP-1s.
Oh, 100%. Because what caught, that has to do with cortisol and insulin. People are, why am I sleeping better? I mean, our sleep is we are so respondent to fluctuations in blood sugars. And, we want those resting low insulin levels at night. And so now we have those. And so we sleep. Headaches. That's another one. Patients are like, I don't have headaches anymore. So it's, the weight is great, but the other side of it is exactly what you're talking about. People are like, I just feel so much better. And joint pain is probably one of the most common symptoms I see with menopause. It's one of the common complaints. Historically, hot flashes got all the publicity, and hot flashes, yes, they are, not a fun time, but joint pain is a really big. Brain fog is another one, definitely helped by these medications. So yeah, lots of other benefits for the people that can tolerate it. There's that small subset that just can't do it, but the majority of people are really happy on it.
I was going to say the majority of my clients, we'll talk about side effects. The majority of my clients have very, very few side effects because I coach them into it, right? I say, I want you to eat an apple before you take your shot, and I want you to take your shot right before you go to bed. And so they're sleeping off the beginning of those kind of off side effects. And then I really, really hammer home, you cannot drink alcohol when taking a GLP-1 because of the slow stomach emptying. And you got to drink 3 liters of plain water a day, not something that you add additives to, really plain water. And then I don't really see very many side effects. I have one, but she still, I think, drinks on occasion. And I talk to her about it all the time, but really, I'm not seeing, if they're coached correctly, I don't see a lot of
I have a very low, I'd say less than, 5% discontinuation rate for side effects. And I also, I think it's also very dose dependent. And they last longer than a week for some people. I have some patients like, I'm kind of nauseous at day 8 or 9. I'm like, okay, that's fine. Then if you're still feeling it, you can delay that a little bit. So some people have a longer effectiveness period with it. And if they want to space that out, that's fine. But I have patients on the other side of it that are like panicking because they're not nauseous and they're still losing weight. I say, not everyone's going to have nausea. So they're losing weight, but they feel like they need to go up because they're not nauseous. That's not the case. You don't have to be nauseous and have a good result from these medications because they're working at the cellular level. That's one part of it, but there's other ways that they're being effective.
And that's interesting because I take tirzepatide myself and I was never nauseous. I just felt full all the time. And then I started asking people, are you really nauseous? Like, do you feel like you have to run to the restroom? And they're like, no, that's not the feeling, but I don't have a way to describe this feeling. So as I started digging deeper into this nausea thing, 90% of people said, no, it's this full, overly full feeling like I ate way too much. I was like, so is that really nausea? So I think that there's when we look at a list of side effects, it's really just lists. There is no I feel overly full as a list of side effects. So they use the term nausea, and I think they're synonymous for most of my.
Yeah, I think you're right. Because that is one of the mechanisms, right? That early satiety that people feel full. And you have to, I also coach people that listen, it's okay if you don't, I think we are programmed to think we have to have 3 meals a day and snacks in between. And that is just such a man-made phenomenon. And some people you just have to, and I tell them, yes, you're on the medication, but if you're not hungry, it's okay to skip that meal. You don't have to eat a full meal because you've done that your entire life. That's not how animals were made to eat, right? So it's okay that is, but I think people are so programmed that something bad is going to happen if they don't sit down and have a full lunch or a full dinner. And you have to get used to that as well. So I spend a lot of time saying, it's okay, have a little something, but you don't need to have a big meal. If your family's having a big meal and you don't feel like it, that's okay. Nothing bad's going to happen. That'll become your new normal. That's, a version of intermittent fasting, right?
Well, and then that's the other thing is what is a normal meal? Most people were eating lots of pasta and things like that as normal meals. And then I tell them, I just want you to prioritize fiber, fruits and vegetables, and protein, because I do get a little concerned with muscle wasting. To be honest with you, I'm not that concerned with it because I'm coaching women that they got to lift weights and eat protein anyway, because they're going to have some muscle wasting as they age. I don't really worry that much about it from the medication, but I just say, when in doubt, I want you to eat two hard-boiled eggs and an apple. So I make it super
Right.
simple. They're like, that's a meal. I'm like, yes, it's a healthy
Yes,
fat. It's a very bioavailable protein source. And
I
you've got a
agree.
fiber and a vegetable and a fruit
Right.
in there. And
Right.
I've re-engineered what they think of as a meal. It doesn't
Right.
have to be a plate of pasta.
Yeah.
And they're like, oh, you're right. That is a meal. And it's actually really liberating for so many of these clients that they're not controlled by what they see in their food
Oh, yeah.
anymore.
Yeah, and I think the food noise too. I mean, for a lot of people, they're like, it's not, I have lots of patients, they're busy, they have their kids, they have their careers, and they're like, I just have more time. I don't have to sit around thinking about what I'm going to eat. That food noise is gone. And I am living, eating to live and not living to eat now. And that's a very, freeing thing. Cause I think at this time in life for women that I see between their 40s and I mean, the weight gain it's devastating to a lot of women, and they are thinking about it, and they're running into my office in workout clothes, eating one nut a day, and they're just so stressed out. So I think just having that freedom that, they don't have to be thinking about this all the time. There's something helping their body. But I mean, I have people all the time saying, what do I need to eat? It also doesn't mean that you're getting a GLP-1 and you're eating, fried chicken all day long. It doesn't work like that either. So
well, that'll make you really sick too.
Yeah, that's not my typical patient, but there are patients that are like, well, I'm on this medication. I don't have to think about what I'm eating. And that's actually not what we're trying to, obviously, like you're saying, accomplish. We want you eating healthy foods, but usually you don't need to think about it, right? Because the medicine sort of internally makes us not want to eat as much.
So I think women right now are really struggling with how to advocate for themselves. We have a political climate where women are that don't know how to navigate advocating for themselves. But then we also have a lot of shame around these GLP-1s.
Oh, right.
How does a patient go to their OBGYN and advocate for themselves and not have that OBGYN say just it's calories in and calories out? Is there a strategy you can share with them that they can use to maybe try a GLP-1 if they think it's right for them?
Well, I think first of all, they probably need to see somebody that is comfortable talking about hormones, because if you're a hormone provider, not all doctors are going to be doing hormonal therapy. Some, in my specialty, some doctors really focused on delivering babies, which is great, but they may not have a busy hormone practice. I think most doctors that are in the hormone business now, like I was saying, they come in for a hormone consult. They're coming in to talk to me about weight gain almost 90% of the time. So usually I'm bringing that up, and I will tell you typically what the response is I'll go through the whole conversation about hormones and talk about all the benefits of hormones, and then I will say, but that is not going to make you lose weight. I think these hormones will do a lot of great things for you. And maybe there is some potential benefit for a very small amount of weight loss. That's not the norm though. But the only thing I think that probably is going to really help us out, because you've already done you're running around in here eating one nut and exercising. I think we should have a conversation about these other medications. And I think patients, you're right, they feel shamed about it. Sometimes they kind of push me off and say, oh, no, I don't want that. And I say, well, why not? And let me tell, I did it. And they say, well, you did. And by the end of that conversation, they wanted to have that conversation, but they feel that they're either copying out, or they feel like, they should work harder and try harder. And, it's hard to do that, so we've all been down that road. Like you said, you've done it, I've done it. It's a medication that is safe and has a lot of long-term benefits, and you shouldn't be embarrassed about talking about it. And if your doctor says, hey, go run or go, watch your diet, then you got to look for someone else that's
well, how does somebody who's 300 pounds go run? That's the part of it that's so crazy is the things that they tell these people, and they're not meeting the patients where they're at. So I always tell people, I think you need to look somewhere else. And I always give them you all the time.
Yeah. And doctors have different opinions, and they're allowed to. Not all doctors are on board about this. I mean, I have colleagues that aren't 100% sold, but they also aren't doing what I do all day long, and which is talking to people about hormones. So I think if it's not their group, but there's some, amazing primary care doctors out there that I have patients coming, their doctors already talked to them about it. They've already submitted the paperwork. The problem is, a lot of it has to do with insurance coverage and costs. And so it is a lot. It takes a lot of time to have that conversation or submit that paperwork. So that's why a lot of people are doing compounded, because it's just trying to navigate your insurance is a bear. And insurance companies don't even know if they cover it half the time. You'll get on the phone and they don't know. So they don't. Patients spend so much time trying to figure out how to get these medications. I think sometimes they just give up. So there are other options. It's still costly. It's not, this is not free. And unfortunately, if you're paying out of pocket, I don't want to say that that's not hard for some patients. I get it, but I think the long-term benefits, if you can do it, are, potentially phenomenal.
Yeah, I agree
Not
with
just
that.
for weight, and there's other things like, that are so important. Mental health, women feel better, people's sex lives are better when they feel better about themselves. There's lots of other things that are, falling off because of the benefits of the medication.
I agree with that 100%. If you had one word of advice, this will be our last question. If you had one word of advice for women that maybe have PCOS or menopausal weight gain, or that are considering GLP-1s, what would that advice be for them?
I would say don't be afraid to go talk to your doctor about it, and don't decide that medicine is not for you until you get someone that's used it and somebody that knows the data behind it, because there's a lot of fear mongering out about it. So, I mean, ask somebody that does that and you will get a positive result and hopefully feel really good when you leave, So I think people feel so good when they, have the conversation. So don't be afraid to ask, because we all, there's a lot of doctors out there on GLP-1. So it's a medicine that a lot of people are using. So don't feel uncomfortable, and know that so many women are going through the same thing, and men.
Yes. Well, Dr. Moore, thank you so much for taking time out of your very busy schedule to talk to me and have a conversation about women's health and GLP-1s.
All righty. Take care.
Have a great day. I want to thank you all for tuning in to the Weightcare podcast. If you enjoyed today's episode, don't forget to subscribe and leave us a review. It really helps us reach more listeners like you. If you are ready to start your GLP-1 weight loss journey, you can go to joinweightcare.com. We'll be back next week with another exciting episode. So until then, keep exploring, keep learning, and keep growing. Thanks for listening. Ciao for now.